First, I'd like to give a warm welcome to our colleagues and faculty and all our contributors out on the Kearney campus. We have some of our faculty here in Omaha, out in Kearney, and it's really great to have this collaboration and partnership with the Kearney Rural Track, and we're so excited. Today we have an installment of our Grand Rounds, which is a School of Medicine Grand Rounds on faculty development. And I will let Jessica Seaman do the introductions from our Phoenix campus. And once again, welcome, Kearney. We're so excited to have you. Thank you.
Thank you so much, Dr. Kim. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development in Creighton School of Medicine. Thank you for joining us for our Medicine Grand Rounds, Teaching and Assessing Clinical Reasoning Skills, featuring Dr. Doug Jones. Just a few housekeeping items before I introduce our speaker. This session is being recorded and you will have access to the recording and the slide presentation for future reference. We invite you to submit questions in the chat and we'll get to as many as we can before the end of the session. We're all on Zoom today, so we ask that you remain muted with video off unless you're asking a live question, just to assist with the recording. Also, this session is eligible for CE credit, and you'll receive the website and activity code before we conclude. There's a very short survey associated with the continuing education, and we thank you in advance for providing feedback as we continue to bring you diverse and robust programming here at Creighton. Now, to introduce our speaker, Dr. Doug Jones received his medical degree from Wake Forest University in North Carolina and completed his residency at Good Samaritan Regional Medical Center in Phoenix. He has worked in GME with residents and learners for over 15 years and also owned his own practice for several years. Dr. Jones has been with the Creighton University Family Medicine Residency for over 4 years as their program director, and we're privileged to have him share time and knowledge with us today as we strengthen our own teaching skills. So Dr. Jones, the time is yours.
Thank you, and thanks for inviting me. I'm excited to be part of your Grand Rounds today. This topic might be a little bit of a departure from some of the things that you typically think of in Grand Rounds, as we're going to be talking about our role as educators. And as you know, all of us as physicians spend so much time learning medicine and learning how to be a physician. And then when we're an academic physician, we're in teaching, and sometimes we realize we aren't taught to the same degree in how to actually be a teacher. So what I'd like to do today is talk a little bit about clinical reasoning and how we evaluate that in our learners, how we help them to develop better skills in clinical reasoning, and hopefully there'll be a few takeaway points that will help you in your role as an educator. So I don't have any disclosures. So these are the objectives, again, to define what clinical reasoning is first. It's something that we do all the time, but sometimes we may not think about it. What exactly does that term mean? We're going to discuss a couple of theories of medical decision-making. First is illness script theory, and the second is called dual processing theory. And then we're going to talk about how to distinguish in our learners between deficits of actual factual knowledge, which if you look at the ACGME milestones is medical knowledge, versus medical decision-making, which is more patient care. And we'll talk about why that's important as we go along. And then we're going to talk about how to help learners increase their clinical reasoning skills. So first of all, usually when I do this, it's part of a workshop that's a little bit more interactive. It's a little bit harder to do that with a large group on Zoom. But I have a couple of polls. The first few are actually, frankly, mostly for me to get to know who's on Zoom here and what is going to be best to talk about. And so this first one is designed to help us just get to know who's here. So if you could take a minute and send in your responses. If you haven't done this before, you can access it through the QR code or by the text above there. Well, let's see who's with us. Give it just a few minutes. It looks like so far we've got mostly faculty, some residents. So residents, thanks for joining us. Hopefully this will be helpful for you in your work with students and other learners, and maybe if you're planning on an academic career. And we have maybe a few students as well, which is great. Okay, next is how long have you been teaching? One of the hard things about talking about teaching is quite often, I'm with a group of people who do this all the time and they've done it for a long time. So the challenge is finding something that might be new for you to learn. So I'm curious to see. It looks like we've got a lot of experienced teachers here, maybe a few who are starting out. The majority, it looks like, have been teaching for quite a while. Okay, good. Well, when we get to the question and answer session, then we'll rely on you to help with some of these questions, for those of you especially that have a lot of experience. Okay, and then the last thing is, who do you teach most? Is it residents or fellows? Is it students, or is it both? So far, it looks like both is winning. Okay, good. So I think we all probably have a sense for what clinical reasoning is. There is a definition according to the LCME, for whatever it's worth. It's the integration and organization and interpretation of information gathered as part of a medical problem, part of medical problem solving. As you suspect, that's pretty generic, and there's a lot more detail to that. Most of the literature on clinical reasoning has to do with diagnosis, probably because it's one of the biggest decisions we make as a physician. It's also one of the most measurable things that we do. However, as you go through your day, whether it's in the hospital, in the office, wherever setting you're in, you're making decisions constantly all the time. So all of that really can be rolled into clinical reasoning. But again, most of the study has been on medical diagnosis, so we'll talk about that mostly. You probably recognize this person and hopefully this quote as well. This is from William Osler. He said, and this is in the late 1800s when he practiced at Johns Hopkins, says, "He who studies medicine without books sails on an uncharted sea, but he who studies medicine without patience does not go to sea at all." So I'm not much of a historian, but I think it's kind of interesting. And if you look at the time period that Osler lived in, back in the early or the late 1800s, which is when residency training formally came into being at Johns Hopkins through him and some of the other physicians that were there. Things have changed quite a bit since then, but I think this quote really is still true, that we're here for patients and we are privileged to learn from those patients as well. None of us would be where we are as physicians unless we had had patients who allowed us to learn along the way as we were caring for them too. But times have changed some. And so the next slide I'm going to show you is going to take us forward about 100 years to something else that you might be familiar with. This report came out in 1997. It's quoted a lot still in medicine, even though it's a couple of decades old. From the Institute of Medicine to Err is Human, when they estimated that 90-something thousand people die in any given year from medical errors that occur in hospitals. There have been several studies since then that have updated that have said that maybe there are even more than that. And this is kind of an insightful graphic it's not from a medical journal, but from the Association of Healthcare Journalists in 2023. That shows you that there are headlines about this still, about medical errors and how important they are. And so I think that teaches us as physicians how we need to be careful, obviously, in our own care. And as we are incorporating learners into our care, like Osler taught us to do many, many years ago, we need to be careful that we are supervising them and teaching them well principles of medical decision making so that they will not only be excellent providers, but safe providers too. So this is the next question. How often do we actually do it right? There is a little bit of data about this. I'm curious to see what you think. So it looks like about half of our participants are saying around 80% of the time, 80, 85, up to 95. So there are a lot of studies, and as you suspect, the answer to this depends. It depends on the setting you're in. It depends on what specialty you're talking about in medicine. There are studies, particularly in internal medicine. This one by Graeber and Associates in 2005 was done in an outpatient setting with primary care internal medicine specialists. And their estimation was that about 85% of the time, 85 plus, a primary care physician in their office will get the right diagnosis. That's probably a little bit higher in the hospital, because in the hospital you have so many resources that are at your fingertips and can get data much more quickly to make a good decision than you can in an office. It also, of course, depends on what specialty you're in. Here today, we're talking about internal medicine. I'm in family medicine. If you look at what are sometimes called the perceptive specialties, things like radiology, pathology, dermatology, those specialties tend to have a higher correct diagnosis rate because it's a different kind of reasoning. That's part of what we're going to talk about along the way. So about 85% of the time we make the right diagnosis, but if you think of all those decisions you make during the day, there's plenty of room, of course, for error. So it's smart for us all to think about how we do it, how do we do it better, and how do we teach our learners to do it better as well. So we're going to focus on clinical reasoning. And in this question, how do learners learn to think like a physician? Is it the result of time and experience, or is it a skill that needs to be taught? Kind of the older thought about this is that if you have spent your 3 years, 4 years, 5 years in residency, whatever your board says you need to be in residency, whatever time that is, that you should be ready to go out and be an independent practice. Right now, the ACGME is really, the pendulum has swung much more towards competency-based medical education. In other words, it's not about time in residency, it's about what you can do. And I would argue that clinical decision-making is a skill that people need to learn, just like putting in a central line, just like reading an EKG, just like doing a surgery if you're a surgeon. There are ways that we can teach this so people are better at it. And if we think about it as a procedure or as a competency, then we may be able to increase the speed at which people learn this, and that they will learn to be better diagnosticians in particular. So why don't we? What are the barriers to this? Well, it's kind of hard. There are a lot of things in medicine that are very much based in data. We look at x-rays all the time. We look at labs all the time. We have what we may feel is concrete data to make a diagnosis on. What we're talking about today is a little bit more of a soft science in some ways. There is some data about it, but sometimes we're not as comfortable with that. And here are some of the difficulties. First, it may be difficult in looking at the learner or listening to the learner and saying, well, what exactly is the problem with their clinical reasoning skills? In other words, diagnosing the learner and finding out what's wrong. We're not trained usually as learning specialists, but we watch a lot of learners as they go through this process. And so I think you probably all have a lot of expertise in this, and you may not actually realize it. Some of it is very subjective. So if I am on the inpatient service for a week with my residents, and I teach them to do something a certain way, the next person that comes on as the attending might not like that. They may say, well, I'd like you to do it a different way. And, we may both be right. So there is a lot of subjectivity in this, and that sometimes is hard for learners, just like it is hard for us to teach to a particular standard. So there is a lack of a gold standard. What is it that clinical reasoning means, and how do we measure it? Time pressure is a huge part of this, particularly in the office. When you have a patient scheduled every 15 or 20 minutes, you have a learner with you, you don't have time to just sit and go through all the complexities of every case, just not reality. The results are not immediate with the learners, so it's not like you can teach somebody something and the next patient they see, they're going to do it perfectly every time. Just doesn't really work that way. And evaluating them and their progress takes a lot of time too. So those of you that are core faculty and sit on a CCC, when you evaluate your learners a couple of times a year, you may have a concern as a committee about how someone is doing. And then 6 months or so later, when you meet again, you all look at each other and say, well, are they making progress or not? Because the progress sometimes is slow. It's often 2 steps forward, 1 step back because of the nature of the variability from patient encounter to patient encounter. So sometimes this is how we feel. There's kind of danger in going there and figuring out how to teach people how to think and how to problem solve, because we may not be comfortable with it. We may not be comfortable with how to evaluate it. So that's what I'd like to do today, is maybe give you some tips on how to do that. I think this is really true with our learners. Better feedback is going to give them better performance. So it's definitely worth learning how to do this so that they can become better at what they're doing. Quite often when we have a student or a resident with us on a rotation, we may see feedback given, things like, well, they need to read more. We may have received that kind of feedback before. And of course they need to read more. We all do. That doesn't really help a whole lot. It needs to be much more specific. Or there's some version of, well, keep working hard and you'll get it. If you keep working at it, you're going to get lots of experience and someday you're going to learn to do this. That can be a little discouraging for a learner. And this is what I call the formula for failure. So feedback plus no tools in order to be able to improve makes just a frustrated learner. If we can give them tools to improve, then they will have a better experience and they'll be able to learn much more quickly. A lot of the work, the scholarly work that's done on diagnosis has to do with analyzing a diagnosis after it's already been made. So it's all retrospective. And you may have seen some of these things before. The cognitive bias in medical education or in decision-making, things like anchoring, blind obedience. These are ways that we describe the biases that we have, or the types of errors that we may make in clinical decision-making. And they're great if you're looking and saying, why didn't that work out the way I thought it was going to? Or maybe evaluating after the fact. But if someone wants to give a learner feedback in the moment during patient care, this doesn't really help a lot. It doesn't help when you're on rounds to say, I think you have diagnostic momentum here. The learner's going to look at you like, what's going on and how do I act on that? This doesn't make sense. So we're going to be talking today about teaching in the context of patient care. What can we do in everyday patient care to strengthen these clinical reasoning skills? So I went through some objectives. These are the things I really want you to be able to take away. We're going to talk about some of the learning science behind this. But what I hope is that at the end of the hour that we spend together, that you may think about teaching clinical reasoning in a different way. Now, I will tell you, I'm going to present some things that are based in data, some things that are based in experience, and some of them may fit with what you do and some may not. And so that different way is going to be different for each of you. I'm not saying that I'm going to teach you the one way to teach other people about clinical reasoning, but hopefully it'll stimulate in you some ideas about how to look at how I can teach this to my learners, and then take away a few concrete things that you can do to help them in the context of patient care to learn better clinical reasoning skills. So to start out, I want to look at how some other people learn. I have a resident right now that's a concert pianist. She spent years and years learning how to play the piano. It's a talent I wish I had. I don't. But I heard an analogy one time that I thought was really insightful. Or if you were a piano major in college, would your professor send you to a soundproof room and tell you to practice a concerto until you got it right, and then come back out and say, how did that go for you? It's not really how we would teach somebody to do this. In order to teach somebody how to play the piano, you'd have to listen and give them tips on what they were doing wrong. I'm not a piano teacher, so I can't tell you exactly, but you couldn't do it in silence. I think the same thing is true in athletics. I love this picture because you can see the coach really getting in there and modeling for this young learner what he needs to do. You can't learn to be a baseball player from a book. It's just not going to work. So you need role models that are going to show you how to do it. And in the same way, you can't really learn to make good decisions without good role models who make good decisions and show you how to do that. So how do we learn? Well, I think we can all relate to this. Either we've been there as a learner or we've been there as a physician. It says, Mr. Raymond, thank you for agreeing to let the medical students examine you. And you see this whole group of medical students there waiting to see the attending show them what to do. That is part of what we do, but maybe we can do it a little bit better than just that. So one question before we jump into the different theories of how this happens is, at what stage in training is it appropriate to start teaching clinical reasoning? When we start out in medical school, the M1s don't have a lot of patient contact yet, so it's hard for them to do that. By the time you get to residency, it's mostly patient contact. So the answer, of course, is what we're going to talk about is relevant to both undergraduate medical education and graduate medical education, but the approach in the two groups may be very different. This is a quote actually that really stuck out in my mind, and it's because I was there when it was said. This is my dean from Wake Forest University the day I graduated from medical school. He said, "You will never know more about medicine as a whole than you do the day you graduate from medical school." So when Dean Janeway said that, I think some of us were kind of surprised. And I thought back and I realized, well, we're all going into different specialties. We're going to do different things. And what he was talking about is the breadth of medicine. You can't really keep everything that you've learned in medical school throughout your specialty training and throughout your career. Once you maybe the peak might actually be when you finish step 3, then you're going to start thinking about different things and you're not going to remember everything about medicine that you learned in school. But the point here, I think, was that school is about medical knowledge. So that's when I graduated, and I found myself just a few months later as a family medicine intern. And in family medicine, we do a couple of months of surgery, and in my program, it was actually trauma surgery. And so that was my very first rotation as an intern. It was really intimidating. I actually really learned to love it. We did a lot of procedures. We learned to evaluate patients in acute settings in a very particular way. And it was every other night call for 5 weeks. And that about killed me. So we don't do that to learners anymore. But back then, that was kind of the standard that every other night we were on trauma call. So that means I would do 24, probably more like 27 hours there, go home and sleep and come back the next day to do it again. So it brings up something, though, with duty hours and the way that we teach medicine now that is actually a change from what it used to be. Several decades ago now, it seems like when I was a resident, that's the dilemma of duty hours. And you've probably all seen something like this before, that if you're only there half the time, you miss half the good cases. I don't know who said that. I'm sure it was probably a trauma surgeon after doing that rotation. So at about the same time, so those two experiences happened to me within a few months. And then at my graduation, I was given a book by one of my faculty by this man, David Lockster-Camp, who's a rural family physician in Maine. And he wrote kind of a memoir of his practice and had some really insightful things to say. And this is one quote that I've used many times through the years that I often refer back to. In school, you are valued for what you know, in practice for what you can do. But who you are is a different matter, something drawn in the lines of duty and given flesh through the relationships you forge over time. That second paragraph obviously has to do with other things besides medical knowledge and patient care. In family medicine in particular, certainly I think in internal medicine and primary care and in a lot of specialties, those relationships are very, very important over time. And that's the way I took this quote at first. It was an endorsement of what I felt I was doing in primary care and how meaningful it was to have those relationships over time. It wasn't until later on that I realized the wisdom in the first line there, that in school, it's about medical knowledge. In practice, including in residency, it's about patient care. So we're going to talk now about the ACGME, which of course is the accreditation body for residency programs, and how all this fits into what we do in specifically with residents, but we're going to talk about students along the way a little bit too. So the answer to the question that I had before, do we learn this more in school or more in residency? Of course, it's really more in residency, but we start with foundations of medical decision-making that are really important in medical school as well. So these are the 6 core competencies that we've all seen before, and we're going to be talking then in the realm mostly of medical knowledge and of patient care. So I often will tell my residents, medical knowledge is what you're gained in school, patient care is what you're going to learn in residency. In reality, of course, there's a spectrum there. You don't stop learning medical knowledge. It's hard to say when you started learning patient care, but there's a definite transition as you get into graduate medical education. So now let's look specifically at internal medicine. Every specialty, and I've actually gone through and looked at a lot of the milestones in different specialties, every specialty has a statement somewhere about clinical reasoning. It may not be exactly in those words, but it's there. Because no matter what specialty we're in, whether we're a surgeon, a psychiatrist, a family medicine doctor, an internist, whatever, we all do medical decision-making and clinical reasoning. So this is what the internal milestone or internal medicine milestones say. Level 1 is to organize and accurately summarize information obtained from the patient evaluation to develop a clinical impression. So that's where learners are probably coming into your programs at, somewhere in that area. And they're continuing to build that skill as an intern. Level 2 then would be to integrate the information. So you're taking the information that you get, the data you receive from the patient, and you're starting to integrate it and put it together at level 2. By level 3, then you're going to be able to develop a thorough and prioritize differential diagnosis for common presentations. 4 is kind of more of the same, but the more complex patients, and that's where we hope our learners get to somewhere around there in the milestones once they graduate and we say that they're ready for independent practice. And the level 5, which is meant to be aspirational, is someone who is able to teach other people how to make good medical decisions, how to make a good differential diagnosis in complex patient situations. So I'm going to give you a case. This is a case that I've used in several presentations from medical school, clear up to teach, talking to physicians that are experienced. We're going to go through it really quickly. It's a simple case, but this is a real case. It's an 81-year-old female, and I've highlighted some of the important information so you don't have to read through it all. 81-year-old female presented with left lower quadrant pain. Her past medical history included some GI problems like GERD, IBS. She'd had a colonoscopy and a CT in the past that showed that she had diverticulosis. On review of systems, she just didn't feel well at all. She had malaise, a lot of anxiety about what was happening, some insomnia. On physical exam, she was quite tender in the left lower quadrant. Labs were pretty normal. UA was pretty normal, no signs of infection. And that's the information that the physician went on to make the diagnosis. So I'd like your input. With that little bit, what do you think the diagnosis might be? Hey, diverticulitis, definitely reasonable. Acute diverticulitis. Constipation, sure, that's very possible. Colitis flare, appendicitis. Get a few more. I like the word atypical. You always have to be looking, is there something beyond what seems obvious? UTI. Okay. Let me tell you the rest of the story. Got a lot of good things coming up there. Before I do that, wherever you are, I want you to do this. Everybody in the world has done what this gentleman in this picture is doing before. Take your hands and put your fingers together like this. When I've done this in workshops, I always ask people, are you right or left-handed? And we found that it doesn't correlate with which pinky is on the bottom. Sometimes people are right-handed, but the left pinky goes on the bottom. So once you've done that, everybody kind of knows what this feels like. Take your hands apart and make it the other way so that the other hand is on the bottom. And think about how that feels for a second. And most people will say, yeah, it feels kind of funny. It just doesn't feel right to do it that way. It's familiar, but it's not quite right. Well, when you feel that feeling, now we're going to talk about learners and how to help them to recognize that clinical sense. You may want to ask some of these questions. What fits with the diagnosis? What does not fit? What else could it be? So here's the case again. What fits? What doesn't fit? And what else could it be? So 2 days later, this person came back to their physician. She was put on Levaquin and metronidazole. She came back really nauseated from the metronidazole, otherwise unchanged. CT scan was ordered and it showed that she had a kidney stone. And if you go back, I kind of set you up for this because in the UA, it says there's no signs of infection, but there was 1+ blood, which is easy to overlook. And that's what the diagnosis was. Okay, we have all done something like this before. We've all had times when we didn't quite get the right diagnosis. These are two theories that help us to know how physicians think, how we do this, and then we're going to talk about how we teach through these theories other people to make the right diagnosis. So the first is illness script theory. This is sometimes taught in medical schools, not always. These are the steps, though. First, we gather information that's usually in the form of history and physical exam, and we get labs, we get x-rays, maybe it's past records, those kind of things. Next, you synthesize that, or you put the data together. And this is the part that I think is really insightful. Each of us has in our brains illness scripts for what things look like. So for instance, if you have seen one case of pneumonia, the first time you were in medical school and you see somebody with pneumonia, you've seen exactly one case, and your illness script will be that. It'll be whatever that patient presented with. But if you are an intern on call on a busy internal medicine service, how many times during the year are you going to diagnose and treat pneumonia? An awful lot. So by the end of that year, you have a lot of illness scripts, which show you the nuances and the variety in community-acquired pneumonia. So now you're able to start to generate a better differential diagnosis because you've seen it more. Once you gather your data, you start to generate that differential diagnosis. A crucial step is to check the data again to make sure it all fits. So the questions that we just talked about, what fits, what doesn't, what else could it be? And through that process, we arrive at a diagnosis. So it looks kind of like this, starting with the data collection, data synthesis, looking for an illness script in your memory. From that, making a differential diagnosis. The crucial step of going back to the data to make sure it fits, just like when you interlock your fingers, it feels right. If it does, then you come out with the diagnosis, and you got to always remember that step of going back to the data. So when we do this as a workshop, I always do this activity. You may recognize the picture on the left side there as a painting called American Gothic, famous American painting. Everybody's seen it, even if you don't know much about art history, it's probably familiar. And we do a puzzle activity. I usually do it in groups where you have two people with a puzzle. Half the puzzles have American Gothic, half do not. And I don't tell them that from the beginning. I just say, okay, I want you to put the puzzle together. That if we're talking about teaching, then one person puts the puzzle together, but the partner has to tell them how to do it. The person putting it together doesn't make the decisions, the teacher does. And going through that experience, we learn a lot about how we make decisions. Invariably, the group that has the puzzle with the picture, of course, gets it a lot faster because in their brain, they have a picture of that. They have an illness script, where those that don't have a picture have a much harder time and have to get more data and fit things together in a different way. So how do you put a puzzle together? It's a lot like clinical reasoning. Data gathering is finding the individual pieces. It's the labs, it's the individual parts of the history or physical exam. Data synthesis is fitting the pieces together. You compare it against an illness script that you know, you build a differential diagnosis, and then finally you complete the puzzle with a diagnosis. Let's look at how that works in the milestones now. So now we're going to talk about evaluating your learners and figuring out where they are in their ability to do this. So level one might be collecting data. Just being able to do a history, do a physical exam correctly, and correct the data. Level two, now you're starting to put the puzzle pieces together and starting to develop illness scripts. As you get to level three, you're starting to match the data with those illness scripts to see what fits, what doesn't fit. Level four is really just doing that in more complex patients, and then level five is being able to teach. So a summary of illness script theory, you can't make a diagnosis that you don't know anything about. So it certainly does take some baseline medical knowledge. The more illness scripts you have in your brain's filing cabinet, the better you can do it. And you always want to go back to the data, especially if things don't seem to quite fit. Okay, next we're going to talk about a theory called dual processing theory. This is not by a physician. Daniel Kahneman is actually a psychologist and economist who won a Nobel Prize, not specifically for this, but for related things. And it's a theory of how we make decisions in general. He says that we have two different systems when we think. System one thinking, which is pattern recognition. So you can see the pattern there, 1, 2, 3, 1, 2, 3. We recognize a pattern and we make a decision based on it. System two thinking is more analytical. It's more like math in the way that we reason. And you can see there the equation for figuring out a GFR. So when we are doing this as a physician, system one thinking is very automatic. It's almost involuntary. It's emotional and it's intuitive. I've seen this before, so I know what it is because it fits with my illness scripts. System two is much more effortful. We have to collect data. We have to think about it. Maybe we get a consult. Maybe we get more labs. Maybe we get more imaging. It requires time and it requires logic and deliberating on what the diagnosis is. So an example of system one thinking, look at this pattern and see if you think you know what that is. There is a pattern to it, and you'll all recognize it in a minute if you don't know it right now. If you know anything about music, I'm not much of a musician, but if you do, now the pattern is probably a lot more clear. Each of those letters was a note. And the more complex you get, and if you add words, now everybody recognizes Jingle Bells. You may not recognize all the notes, but you know the song. And if you are a really good musician, you understand a lot more of the complexity of what's happening there. System two thinking, on the other hand, is this. It's like doing an equation. This is why we all do lots of physics and math and chemistry to get into medical schools, to teach us how to think like a physician in this analytical way. Okay, to end now, we're going to talk about how do we apply that to our learners. So when you feel this way, when somebody presents to you a case on rounds or in the office or whatever it is, and you feel like things just don't fit, this is a question you might start with as the teacher to evaluate how the learner is doing on their clinical reasoning skills. Is this a medical knowledge problem or is it a clinical reasoning problem? Because they're very much related. You can't completely separate them, but they are different. There are different milestones associated with them, and they're different skills in some ways. So if you're evaluating medical knowledge and you want to know, does the learner know what they're doing? Do they know the facts? Can they recognize the individual puzzle pieces? You might ask questions like, tell me what you know about acute diverticulitis. What's your understanding of how metformin works? What's a typical presentation of pneumonia? If they understand illness scripts, give me an illness script. What's your illness script for irritable bowel syndrome? Or how does something work? That's going to help you to decide, is this a medical knowledge problem? Do they just need to learn more? They don't know. Remember, you can't make a diagnosis about something that you have never seen before. But if you want to know, is there deficit in clinical reasoning, ask questions about the process of clinical reasoning, like, how did you decide that this was acute diverticulitis? How sure are you of that diagnosis? What fits with the diagnosis? What doesn't fit? What else could it be? So now you're asking not about the medical knowledge, but about the process they used to get to that diagnosis. So now we're going to do a teaching case. This is a 34-year-old female that presents to the outpatient clinic. If you do any general medicine in an outpatient clinic, you're going to recognize dizziness is one of just the hardest things that we deal with. So one-day history of dizziness with severe nausea and vomiting. It's constant, worse with any movement. The patient is seen in the residency clinic by an intern in July. How many times have you heard that before? We're setting it up for something, right? Who has never seen a patient with dizziness before, and diagnosis benign positional vertigo. Well, there's a long differential to what dizziness could be. As you know, dizziness is really not a medical term, it's a lay term. So you got to figure out, is this really vertigo or is it something else? We won't go through the differential diagnosis because that's not the point. But you might work with that learner to say, what's the typical illness script for BPPV? And these are the things that it should be. Probably the biggest one that doesn't fit is it only lasts for a period of several seconds where the patient had dizziness that was constant. So in this case, things just didn't seem to fit. But is the error with medical knowledge, clinical reasoning, or both? Well, it could be both because this is an inexperienced learner. And so you have to take that into consideration. But as you're trying to help them think through it, you may want to take one path or another. So you might ask questions about facts. like, tell me what you want, what you know about benign positional vertigo. What's your understanding of it? Give me a typical presentation of it, because as you can see, this was not a typical presentation. If the answer is medical knowledge, these are some of the things that you can do to help them to gain that medical knowledge. First, of course, is a safe environment for them to ask questions. Using point of care resources, going to articles, inviting the learner to read more, assign them to read. We all kind of know those things. That's intuitive. Those are the ways that we get medical knowledge. But what if it's more about clinical reasoning? Now you might say to the person, how did you decide this was benign positional vertigo? How sure are you of the diagnosis? What fits, what doesn't fit, what could it be? Strengthening system one skills, there's no substitute for just seeing lots of patients. When that same learner has seen 30 people with dizziness, they'll probably be able to come up with a better differential diagnosis. Because residency time is limited, we're not on call every other night. Simulation is sometimes helpful. Electronic or paper cases can be helpful to learn in a way that doesn't jeopardize patient safety and patient care. How else could this problem present is a great thing to ask your learner. Okay, you got the diagnosis, that's great. Now you've seen one pneumonia. How else could pneumonia present? Let's learn a little bit deeper. Study other possibilities on the differential. So yes, it turned out to be a kidney stone. But the other things in our differential were all GI things. What if it was ischemic colitis? What if it was Crohn's disease or something different? Strengthening system two skills is a little bit more of a challenge, but the first thing you do is slow the learner down. We know that system two is that analytical thinking that we all flip into once we don't know the pattern. And by the way, we don't really mention it, but an experienced physician actually spends about 90% or so of their time in system one thinking because you've done it enough that you recognize the patterns, and maybe 10% of your time in system two thinking, where you really do have to think through a diagnosis and you're really not sure from the beginning what it is. But it takes more time. So if you slow the learner down, ask them the questions that we've already talked about, help them to think through it, make or reinforce the connections between the data points. Guide them through the process, help them to actually put the puzzle pieces together. So in that case of vertigo, you might say something like, how does the vertigo relate to the nausea? If in BPPV, it's a pretty brief episode. Sometimes patients don't get the same kind of nausea that they may if they have vertigo for a longer period of time. How do those things relate together? Or ask if-then questions. If I give this patient this antibiotic, what do you think then will happen? This is a really powerful thing for teaching clinical reasoning skills. They're going to learn most of what they learned from watching a senior resident or an attending do their work. So if you are working with a resident or a student, one of the best ways you can teach them is to think out loud. So yesterday I was seeing a patient in clinic here that had diabetes. It was a fairly complex patient, and working with a student, and the approach that I decided to take was to say out loud, when I see these kind of patients, this is what I'm thinking. This is what I do next. This is how I adjust their insulin, so that they hear how I think through it. And that helps them to be able to figure out how they're going to do it as well. Okay, the last point, and then we'll have some time for questions. I think you probably all know this kind of a learner. It's the nonlinear presentation. It's the person that seems to be disorganized, that instead of going through a presentation saying, oh, instead of A, B, C, D, E, it's like A, D, B, F, G, not in order, getting confused by details. This is the learner that is fixated on what the pieces of the puzzle look like, what color and shape they are, not how they fit together, or that they have a hard time making a decision. This is one way to help with that, and this is a system two thinking skill, is from the beginning, have them give you an assessment. Don't start with the subjective. Have them come to you and say, I think this patient has benign positional vertigo because. So they're committing to something. Then they go back and give you the whole presentation as supporting data. That helps them if they have a hard time going through all that data and still not being able to come up with what's my diagnosis. Okay, the final step. So this is common in evaluation. It says there's nothing about your performance that you need to change other than everything. Your job as a teacher is not finished until you do an evaluation and give feedback. I think sometimes the best thing you can do is reinforce the good things that the learners do. Say things like, I really like that you did this, or how you did this, because I think you are correct because, and that word because is really important, because saying nice job makes us feel good, but telling us why we did a nice job makes us a better physician. I like the way you handled this because. So reinforcing the positive clarifies what your expectations are. It shows, yep, you did it right that time. That one was good. Keep doing it that way. Builds confidence. It helps learning become more concrete. Now they know the target. That's what I need to do on every case. Teaches them what good really looks like. So in summary, we've talked about the importance of clinical reasoning, some theories of clinical reasoning, how to recognize when things feel uncomfortable, when your fingers don't fit right together, and you need to ask more questions, how to assess medical knowledge with content questions, assess the process with process questions, and takeaways here. Recognize the difference between medical knowledge, which is content, and patient care, which is more the process. How to strengthen the system 1 skills by building more illness scripts, strengthening system 2 skills by helping them make connections and put the pieces of the puzzle together. And showing your work as you do that so that they see someone's experience and how they reason through problems, giving them positive reinforcement where it's where they should get it so that they know what good looks like and how to continue to do good things. Since it's March Madness, last parting shot here. It's the little things. You'll probably recognize John Wooden. Hopefully you do, as one of the greatest college coaches ever. And that's Kareem Abdul-Jabbar, who was one of his players. It's the little things that are vital. Little things make big things happen. So each of these individual things are little, but as you continue to do them with your learners, they will get better and better. And because it's March Madness, go Blue Jays. All right. We have a few minutes for questions. I'm going to stop sharing here.
Thank you so much, Dr. Jones. Such tangible information and ways that we can work with learners. So really helpful. Anyone can unmute themselves if they would like to ask a live question, or you can certainly put questions in the chat.
This is Tina Younger. Thank you for this wonderful session. It just put together so many things that just really needed to kind of be all put together for all the faculty, I feel. It was amazing. So I have one question. I noticed that you highlighted the feedback as the positive aspects, when sometimes we will need to give feedback that may be deemed as negative. Like, I see that you have done such and such. Maybe tell me more about that. So I'm just wondering if you have some advice on when you need to give a little bit more corrective, because it is important to give the positive for sure, but sometimes there are things that really do need to be given as corrective, more feedback, I would say.
Yeah, thanks for the question. And of course, we could do a whole presentation on how to do that. It's a difficult thing. And Dr. Younger, I think you actually started it off well in the way that you asked the question. You can use that same because phrase, I think, if people need some corrective action there, to say, maybe something like, I'm concerned about this decision because, or I think we should look at this case because, and be very specific with them and what you see that maybe they need to do differently. It's important, I think, to be objective there, not to say, gee, you did a bad job because, where when you do a good job, we're quick to say you did a good job, but you want to still be neutral to positive in how you do it. Let them know that we need to talk about this because, and then I think following it up with a statement like, I'd like to understand why you did this because I want to help you to be able to do it better, so that you're there to support them. Sometimes it'll be a really helpful way to do that.
Thank you.
Dr. Kim, do you want to go ahead? And then we've got one in the chat.
Sure. Doug, thank you for the presentation. A question regarding how do you approach a struggling learner that has more of a chronic problem separated by either, medical knowledge or the process, clinical reasoning? How do you approach those two different scenarios?
Tell me more about what you're asking here. So medical knowledge versus patient
Yeah, I mean,
care,
do you
or
approach, a learner that's struggling with medical knowledge differently than a learner that's struggling with the process of clinical reasoning?
yes, I think so. And that's why I think it's important to make the right diagnosis there as the teacher. Is this about learning more, or is it about doing better? I think we've probably all seen learners before that did great on their boards, but they struggle with patient care, or some that their scores aren't great, but they actually take really good care of patients. And so I think helping them develop a plan to address that specific deficit is what we need to do. So if you decide, once you have reasoned through this, that their problem is really with medical knowledge more, then making a plan around medical knowledge, giving them assignments to read, having them do review questions, whatever it is, and monitoring that in the context of patient care to make sure they're doing better is the thing to do. The thing that we often do is just say, read more, when the problem was really patient care, when they actually know things. And if they were to take a test, or if you ask them a question, they know the right answer, they just don't know how to do it. And so that's when you have to help them with the decision making. Don't worry about saying, read more, learn more. Help them through learning to put the pieces of the puzzle together and actually apply that to the patient. Does that answer your question?
Yes, thanks, Doug.
All right, we have a couple questions in the chat, so I'll go ahead and start. Has the use of the EMR changed the way learners present patients?
I think it very definitely has. Yeah. And sometimes this is a challenge. I think because we use templates so much in an EMR, doing a presentation that concentrates on medical decision-making and diagnosis is kind of becoming a lost art. There's so much data that just gets put into the note automatically for us, and a template that's loaded automatically, that learners sometimes aren't able to think through the data in the same way. So there's two things that I have noticed that I kind of do differently because of that. One is when I'm starting with a student, when they are first learning, I will often tell them, I want you to present the patient without using the EMR, just from the notes that you have and the things that you've learned, or even more basic than that. Write up an H&P from me of a totally normal patient, independent of what the template physical exam is. And then with more experienced learners, I will often talk about a case either in the office or on rounds, and then I'll often pull up their note and compare their note to what they told me and say, okay, this is what the note says because it was all pulled in automatically. This is how you told me you thought through it. Tell me how similar or different those are. And it helps them to realize that they can't always rely just on that template.
That's a good way to have them compare those two ways. Another question, Dr. Jones, is how do you think AI will be used in conjunction with in-person experiences and potentially increase diversity of cases?
Wow, that's a great question. And I don't know if any of us know the answer to that yet. I think there's a lot of potential with AI for us to use it in simulated or electronic cases to increase the number of illness scripts that people learn. It would be really great to be able to generate cases so that you could learn a lot of different things about a particular diagnosis. Obviously, the pitfall is that if we rely on it too much instead of our own clinical reasoning, that's going to be a problem. So I think it probably is in just this context of learning how to make clinical decisions, has a big upside in undergraduate medical education as you're learning those illness scripts, and a real danger zone for residents and physicians in relying on it too much when there's really no substitute for your intuition and your decision-making as a physician. So I think that's what we're going to need to look at down the road.
being able to take the pros and the cons of that AI and to be able to use it appropriately, for sure. I do not
Yep.
see any other questions, and we're right at the top of the hour. Any questions from those that want to unmute? I don't see any other hands raised. Dr. Jones, thank you so much. We really appreciate your time and sharing your knowledge, and we will make sure the recording and the slides get out to everyone.
All right, thank you.